Hello, everyone, and welcome. Thank you so much for joining us here today for our webinar on women and heart failure from diagnosis to innovation. I'm Jody Smith, the Director of Strategic Alliances here at WomenHeart, and I'm delighted to be here with some wonderful presenters today. I would also like to thank our sponsor of this webinar, AskBio, for supporting this important conversation and making this possible for all of us to have this webinar today. Today, our focus is on heart failure, and this is a complex and growing health concern affecting millions of people in the United States. This disease, heart failure, often looks different in women, and understanding how heart failure presents and progresses in women is critical for women to get the care they need. And that's one of the reasons we're doing this webinar today. This presentation and discussion will cover early symptoms, causes of heart failure, the difference between, I'm going to say acronyms, HFPEF and HFREF, which one is heart failure with preserved ejection fraction and one is heart failure with reduced ejection fraction, which Dr. Lindenfeld, I'm sure, will explain in greater detail. We will also explore current treatments, future innovations like gene therapy, and what this means for women living with heart failure. I am joined today by Dr. Lindenfeld, and I am also joined by Kimberly Cannell and Sheila McCarr, who are two WomenHeart champions who will share their journey with us today. I want to introduce to you Dr. JoAnn Lindenfeld. She is a nationally recognized expert in heart failure. Dr. Lindenfeld is a professor of medicine at Vanderbilt University Medical Center. She has had a long-standing interest in heart failure and also cardiac transplantation, which we know some people with heart failure have end up having a heart transplant. She served as the section director for heart failure and transplantation at the University of Colorado and subsequently at Vanderbilt University Medical Center, where the program grew to become the largest heart transplant program in the world. She has received numerous honors, including the Leonic Society Award for the American Heart Association, as well as a Pioneer and Lifetime Achievement Awards from the Heart Failure Society of America. She served as the principal author of the Heart Failure Society of America's Heart Failure Guidelines and has contributed to the American Heart Association, American Cardiology, and Heart Failure Society of America Guidelines Committee. Dr. Lindenfeld has helped lead major clinical trials and served on both the FDA cardiorenal and cardiovascular devices advisory panels. She is a founding member of the Heart Failure Collaboration and co-founded the University of Colorado Women's Center for Health Research, the largest center in the world focused on cardiovascular disease and diabetes in women. So as you can tell, we have a really wonderful honor of having you, Dr. Lindenfeld, join us here today. And we're looking forward to learning a lot from you. And I will now be quiet and let you take it away.
Jody, thank you very much. It's a pleasure to be here, and I'm looking forward to presenting this and then hearing your questions. So next, as I want to just show you my disclosures, which will be on the next slide. And I do consult for a number of companies that develop new medications and devices. And so just be aware, and I'd be happy to be asked about any of those. Next. So I want to spend just a minute here because heart failure is what we call a syndrome. We often call it a disease, and I do that too sometimes. But heart failure is caused by a number of different diseases, all of which interfere with the heart's ability to pump blood adequately to the rest of the body. So it's a syndrome of signs and symptoms that result from the heart's inability to pump adequate blood to the rest of the body. So the diseases that can create a problem in the heart are numerous, but really the three most common are diseases of the coronary arteries, which cause heart attacks, atherosclerosis, heart muscle disease, a primary disease of the heart muscle itself. Sometimes we call that cardiomyopathy. and then diseases of the heart valves. But there are literally 100 other diseases which cause heart failure less commonly, but importantly for whoever happens to have that particular illness. Next. So this is just a picture of the heart, and in red, those little worm-like things on the front of the heart are the coronary arteries. And this is probably the most common cause of heart failure, when one of those arteries is blocked by an atherosclerotic plaque. And when the artery is blocked, the muscle beyond it does not get adequate blood supply, and the muscle dies. And that means a portion of the heart doesn't function normally. And when that happens acutely, when it happens acutely, there can be abnormal heart rhythms, which can be life-threatening. But on a more chronic basis, you lose heart muscle, and the ability of the heart to pump is diminished, and it can't put out the same blood supply to the organs, and the blood backs up in the lungs, and that's the syndrome of heart failure. So in the United States and in much of the Western world, heart attack is the most common cause of heart failure, but there are a number of other causes. Next slide. So here you see a schematic of the heart opened up, and on the right hand, that big muscular chamber on the lower right hand side that's the left ventricle, and then the right ventricle's over on the left hand side, and we see there's valves. The valves open and close in the heart in order to allow the blood to be stored, and then that chamber closes, and then it's pumped out to the body. And simultaneously, the blood that gets oxygen from the lungs is pumped out to the body, while the blood on the right side of the heart is pumped to the lungs so that it can gain oxygen and then be pumped over to the left side. And so all these valves perform the function of opening and closing, just like locks do, to keep the water at a certain level. And then there's also the heart muscle I pointed out there that can become damaged. That can become damaged, as we talked about on the last slide, by a heart attack, or there are diseases of the heart muscle. For instance, a dilated cardiomyopathy, meaning that the heart muscle just becomes weak and you lose heart muscle cells and the heart becomes dilated. There's other causes like hypertrophic cardiomyopathy, which is not rare, where the heart muscle gets thicker and thicker and limits the internal chamber of the heart, so there's just not enough blood to be pumped out and the heart becomes very stiff. Furthermore, any of these valves can either leak backwards, which means the forward flow of the heart is inadequate, or then they can become blocked or stenotic, and the blood can't get through them adequately and then out to the body. So these are the most common causes of the heart failure, but there's a number of others that may come up in our discussion. Next slide. So once again, I want to talk about the signs and symptoms. And I think in this schematic, what you see is that in the blue, the blood comes into the right side of the heart from all the veins of the body. And that blood has lost oxygen because the oxygen's been released in the body to nourish the organs. So the blood comes into the right side of the heart, and then you see in blue, it goes out to the lungs and through the lungs where it gains oxygen in the lungs. The purpose of the lungs is to allow that blood to flow through it and to place oxygen on that blood. Then that blood becomes oxygenated, which is in the red side, comes back to the left side of the heart where you see that big red arrow, and is pumped out to the rest of the body. If the heart can't pump out the blood to the rest of the body, if there's a problem because of heart muscle disease due to a heart attack, or because of a primary disease of the heart muscle itself, then the blood backs up into the lungs leak and get wet. And when the lungs get wet, it's harder to breathe. The lungs are stiffer, and that makes a person short of breath. So when the blood backs up into the lungs from the left side of the heart, the lungs leak fluid and get stiffer, and shortness of breath results. So when there's back up to the left side of the heart, there's shortness of breath both at rest and with exercise. Shortness of breath often with lying flat because there's fluid in the lungs. And if you lie flat for a few minutes, then you begin to notice shortness of breath, and sitting up allows that blood to go down to the bottom of the lungs and you're less short of breath. Another feature of shortness of breath that's not uncommon is that people will go to sleep and fall asleep and can lie flat, but a couple of hours, and the 2 hours is pretty specific. About 2 hours after falling asleep, they wake up suddenly short of breath. And the reason for that is that the blood that is accumulated in the legs during the day when you're up and about, we all know our legs swell a tiny bit during the day. And that fluid then, when you lie flat, comes back to the heart. And as it comes back to the heart can't pump it all out and it backs up. So that's a very specific sign of heart failure, is to wake up. There's a lot of things that wake people up, but 2 hours after you go to bed, that's a pretty classic time for this. And then one other manifestation of this backup of fluid in the lungs is that people often complain of being short of breath when they bend over. For instance, bending over to pet the dog or bending over to tie their shoes. they notice shortness of breath. So those are all the features of the fluid backing up into the lungs. Next slide. Now, when the fluid backs up into the lungs, then that raises the pressure in the lungs. And that makes it harder for the right side of the heart to pump out blood. So the pressure goes up in the right side of the heart. And when the pressure goes up in the right side of the heart, that means the pressure goes up in the neck and the brain and down in the kidneys and the liver. And that makes it more difficult for all those organs to function. So the kinds of symptoms and signs we see are next on the next part. And that's ankle and leg swelling. People usually notice the swelling in their legs, in their ankles first. And that's usually in the evening when you've been up all day. And then very often that swelling will go away at night and won't be present in the morning. And when that swelling gets mobilized, that's what causes some people to wake up in the middle of the night and have to sit up, because that fluid is being reabsorbed into the body, but the heart can't quite handle it. So about 2 hours after you go to sleep, there's too much blood in the heart. It's backed up into the lungs. The person gets short of breath and wakes up and sits up. The same congestion of the liver and kidney causes pain over the liver. Often, rarely the kidneys hurt, but most often what we see is that dysfunction in the blood tests that show us how the kidneys are functioning. So those are all those things of signs of the blood backing up on the right side of the heart. Next. And then finally, the blood backs up and creates these symptoms of congestion in the lungs and congestion in the body and the ankles and the liver and the kidneys. But also when the output of the heart is not adequate and a person goes to exercise, the output of the heart can't increase and supply blood to the muscles to exercise well. So the person has fatigue, may have muscle fatigue, particularly, as well as shortness of breath when they exercise. So there's fatigue, poor exercise capacity, sometimes mental fuzziness, and then all of these things together often, well, if they're severe, will make a person lose weight because the blood's backing up in the liver. People don't feel hungry or they have nausea. They're tired all the time. They're not sleeping well. All of these are all the signs of heart failure. So when I say heart failure is a syndrome, it is a syndrome of these signs and symptoms that's caused by a large number of other diseases, the most common of which are coronary artery disease, disease of the heart muscle, and valve disease. But there are a number of others. Next. So I think you'll often hear the term ejection fraction, and many of you may know what that is, but I know many people don't. And the ejection fraction in the heart is the amount of blood that the heart squeezes out with each beat. So a normal heart in an average sized person holds about 100 milliliters of blood. 100 milliliters, 15 milliliters is a tablespoon. So about a little over 6 tablespoons. And then it squeezes out about 4 tablespoons with each beat. At rest, the heart doesn't squeeze out all of the blood within a normal heart. So 60 milliliters over 100 milliliters is 60% that the heart squeezes out in this particular example of a normal heart. And usually we say a normal ejection fraction is above 50 to 55%. It may depend a little bit on the laboratory and the institution in which you're in, but especially above 55% is normal. Next. So the terms, and Jody mentioned these earlier, is how is heart failure described? Well, we describe it as heart failure with what we call preserved ejection fraction. So the ejection fraction is at least 50% or more. Heart failure with mid-range ejection fraction, that is, it's 41 to 49. Or heart failure with reduced ejection fraction, less than or equal to 40%. Now, I want to stop here for a minute before we do anything else and just say that this is sort of a historical way of we describe things, because for the longest time we thought of heart failure as just those people who had a reduced ejection fraction. We abbreviate that as HFREF for reduced ejection fraction, HFPEF for preserved ejection fraction, and the mid-range is harder to say, but that's still an understudied area. But for years we thought about heart failure as people who have reduced ejection fraction. And then in the mid to late 1990s, we were doing a study, an NIH-sponsored study of a beta blocker in heart failure. And we wanted to enroll men and women, but we were having trouble enrolling women. And so I was asked to look around and see why we couldn't enroll more women, because even at that time, we knew that there were just about as many hospitalizations for heart failure in men as in women. And what we discovered at that time, and we wrote an editorial at that time that was entitled, "Where Are All the Women with Heart Failure?" And what we discovered was that there's as many women with heart failure, but women more often have this preserved ejection fraction that is of more than 50%, whereas men more often have a reduced ejection fraction. And why is that? Well, that has to do with what causes these two. There's a lot of overlap in what causes them. But if we look at the next, if we'll click next, what we'll see is that usually preserved ejection fraction is due to one or a combination of high blood pressure, diabetes, and obesity. And this makes the heart stiff and fibrotic. With reduced ejection fraction, that's usually due to heart attacks or heart muscle disease, and the heart becomes dilated and sort of baggy and loses muscle cells. So women more often have this preserved ejection fraction. Men more often have reduced ejection fraction, but there's a lot of overlap there. Next slide. So are there differences in men and women with heart failure? There's a number of differences, but the symptoms are often very similar. As I said, women have heart failure with preserved ejection fraction or HFrEF more often than men, while men usually have heart failure with reduced ejection fraction. And that's to a great degree because men have more coronary artery disease than women. And HFpEF is sort of disease of older women, usually postmenopausal. And I said those things are primarily due to the combination of high blood pressure, obesity, and diabetes, particularly type 2 diabetes. Women less often have coronary artery disease. So that's why those two types of heart failure are different between men and women. For any ejection fraction, women have a lower mortality than men, but always have more symptoms. And we're still trying to figure out why that is. On another occasion, we can come back and talk about that, but we're starting to figure that out a little bit. But I just will go back and say, repeatedly for years now, we've known that despite having a slightly lower mortality, women have more symptoms and more disability with heart failure than men. Treatments pretty much benefit men and women equally, but there are some exceptions, but they're usually not severe. So I want to cover just a little bit generalities about treatments for heart failure, and we'll get into more specifics. Prevention always comes first. So coronary artery disease could be almost not completely prevented because there are some genetic problems, but coronary artery disease and heart attacks could be largely prevented by treating high blood pressure, diabetes, obesity, and by not smoking. If we really did a good job at all those things, very few people would have coronary artery disease. About half from heart failure with HFrEF then could be prevented by preventing heart attacks, at least half. Most of heart failure with preserved ejection fraction could be prevented by addressing high blood pressure, diabetes, and obesity, and the lack of exercise in our population. And I would just point out here something that's very important in women, is that we've always attributed the increase in heart failure with preserved EF at the menopause with estrogen and those kinds of things. But it turns out, starting about 4 years before the menopause, women reproducibly start to exercise less and less. And about 50% less, actually. So one thing we have to think about is we're going to have to really have a nationwide referendum on making sure that we realize that and start to continue to exercise well as we approach the menopause. Next. Now, I've put the major treatments here for the types of heart failure we have, and here I've put the treatments that we know reduce hospitalizations and improve how long a person lives. And this has we've really had major advancements now, so that the person with heart failure and reduced EF in today's world, if treated properly and complies with all the right treatments, will live another 10 to 15 years longer than they would have. That's 10 to 15 years longer, and some more than that. So the treatments are diuretics, the water pills that take out the fluid, beta blockers, a class of drugs that includes the angiotensin converting enzyme inhibitors or ACE inhibitors, angiotensin receptor blockers or ARBs, and angiotensin neprilysin inhibitors. Now, just to say, for instance, lisinopril is an ACE inhibitor, valsartan is an angiotensin receptor blocker, and Entresto is the only angiotensin neprilysin inhibitor that we have. Mineralocorticoid receptor antagonists, spironolactone, eplerenone, and now finerenone. And then sodium glucose cotransporter 2 inhibitors. There's more than one, but you'll remember is the little pill with the big story to tell. All right, so empagliflozin, dapagliflozin. And then there are devices. There's implantable defibrillators that people have, so that if they have an abnormal heart rhythm, this will detect it and give them a shock to shock their heart back to normal. There's something called cardiac resynchronization therapy, which when the heart becomes discoordinated, paces the heart in two spots and makes it perform in a more coordinated fashion. And then often when the heart gets large, the mitral valve, it pulls apart the leaflets of the mitral valve, it leaks severely, and we can now go in with a catheter and clip that. So each of these therapies reduces the progression of heart failure and reduces the risk of sudden death with heart failure too. And the changes this has made have been huge over the years. But there still is a lot of problems with heart failure and reduced EF, despite all of these therapies. So we need more. Next. Heart failure with preserved ejection fraction, we have 3 medications now, much less. Diuretics, the sodium glucose transporter CoA2 or SGLT inhibitors, and dapagliflozin. And then the new ones, the obesity drugs, glucagon-like peptide antagonists, which are tirzepatide and semaglutide, those are only indicated for heart failure. They're indicated for obesity. They're only indicated in heart failure if the person is also overweight, substantially overweight. There are no specific devices for HFpEF that change mortality. So on the last slide, just to summarize, I've shown you a number of treatments that lengthen life and improve symptoms. Those are the ones I've mentioned. But there are other medications and devices that have more modest benefits and are not used in everyone, but there are specific types of diseases or specific symptoms for which they can help. So there are new medications, heart monitoring devices, gene therapies, and new device treatments that are being developed every day for a number of treatments of heart failure. And for last, I just want to say thanks everyone for your attention, and I'm very much looking forward to the questions and the discussion.
Okay, Dr. Lindenfeld, this was so informative. I took so many notes. I was taking notes while you were talking because, this is very fascinating for me, and I think for a lot of women, and explaining the differences between women and men when it comes to heart failure, like especially the study, where you were looking for the heart failure patients, the women who are heart failure patients. And I thought, well, I can totally relate to that as a woman living with HFpEF myself. And we have 2 lovely speakers coming on in a little bit who also can share their story about heart failure that they live with. But I have a few questions for you. So I'd like to dive a little bit deeper into some of the topics. And you were talking about the exercise. Like, I also was very fascinated about the exercise issue 4 years before menopause, because I'm just like, somehow we have to figure out what's going on there, because we all know, like all of us women, or anyone who is living with HFpEF, which is, as you said, caused by obesity and diabetes and high blood pressure. We know to exercise and we know to eat healthier, yet despite the knowledge, heart failure is rising in America, and HFpEF is getting more common as well, and especially among women, from what I understand. So do you have thoughts on what exactly is going on and how we can help prevent, how women, just anything that women can do, as I'm focusing on women here, to change that narrative to help prevent having heart failure in the first place?
Yeah, I think that the most important things are, of course, prevention. And what we can do to prevent both types of heart failure are we can make sure our high blood pressure is treated.
Mm-hmm.
We can make sure that we're treating diabetes adequately, or preventing diabetes by preventing overweight. And overweight. So overweight is another big thing. And then we can get adequate exercise. And eating well is always important. And then not smoking, and all of those things also. And then treating lipids, treating your cholesterol and triglycerides. If those are elevated, then we'll help prevent coronary artery disease. So the obesity, high blood pressure, diabetes, smoking, cholesterol, those all prevent coronary artery disease. But those can cause HFpEF and do, but they also cause HFrEF. But if we do all of those things to a great extent, we can prevent an awful lot of the heart failure that occurs in the United States, and particularly heart failure with preserved ejection fraction, if we can do those things.
Yeah. So, I think as WomenHeart, I think we can try to think about that and think about ways we can support women in coming up with plans. We definitely promote, treating these different conditions if you have them. And we know that women, as your estrogen lowers, that's very protective in a sense of your blood vessels getting stiffer, and also your cholesterol level. So we can look at some of that. And speaking of medications, you listed a bunch of different medications, well, more for HFREF, but a bunch of different medications people can be on. And I think one of the things is, a lot of people feel like, I just don't want to take all these medications. And so if someone needs to go on the medications, and you said they increase your years by 10 to 15 years, I was like, that's pretty cool. But is there a time where they can get off of them? Are they going to be able to get off of them, or how does that work?
Yeah, that's a really important question. So most of the medications and most of the benefits so far has been in HFREF, because that was the first heart failure with reduced EF. That was the first thing that we addressed and tackled. And so we made a lot of pride there. For most patients with HFREF, the medications are lifelong. And that has been shown now that if people go off the medications, at least half of them within 6 months clearly get worse again. And I think it's really important for people to understand too, with heart failure and reduced ejection fraction, if you go off all your medications and you get worse again, we can't always recover it. So more damage happens when you do that if you stop taking medication. So that's really, so there are certain situations, for instance, when someone has heart failure just around a pregnancy or so-called peripartum cardiomyopathy, then very often after a year or two, if the heart has normalized, we will withdraw the medications. There are some other things that are less common, a thing called Takotsubo cardiomyopathy, where there's sudden severe damage to the heart, but then it recovers completely. Medications can usually be drawn in that situation. So there are some specific things that damage the heart where if we can control the underlying disease completely and get rid of it, then we could stop the medications. But I think that's probably only about 10 to 15% of all of the HFrEFs. Now, HFpEF can be improved substantially. I think we are just beginning to see that if we have someone who has type 2 diabetes, high blood pressure, and obesity, if we reverse the obesity, we make the blood pressure better. If we treat the blood pressure, we can get it down to normal. If the person exercises normally, and then treating the obesity gets the diabetes better, I think that HFpEF could certainly be stalled in its tracks, and it probably almost certainly improved. We know we can improve it. We know we can improve the ability to walk around and the amount of shortness of breath that a person has. So there's a lot that can be done here.
Well, that's promising and exciting. And, I know with WomenHeart, we advocate for, access to these therapies that will help with those conditions. So we'll just keep on with that since that seems very important. But when you talk about the HFpEF in women and it being more common in women than men, what do you see as some of the major challenges that women face with HFpEF, and how can they advocate for themselves?
A really important point, because I think we know that women take care of the whole family in general,
right,
and usually put themselves last.
Yeah.
And so I always like to remember, I think we all need to remember what they tell you on the airplane is put on your own mask first. Because if you don't take care of your health, it's going to be much harder for you to take care of your family's health. Right. So family events, when that's possible, walking, family events, dinner, then get up from the table, no seconds, and go out walking. All those things can be done in families or groups. And I think we also, many of us have a buddy system for breast cancer and have had for years. We can have a buddy system for, going for a walk, taking our blood pressure, doing those kinds of things as well. So I think, women tend to be much more social, and utilizing that ability is enormously valuable for your health.
Yeah. Well, it's, I think, as you said, so many women put themselves last. And I think that is one of our biggest challenges, because we want to take care of everyone else. And we have nurturing, many of us, this is stereotypical, but it's true. I mean, many of us have very nurturing, caregiving types of behaviors, and it's not towards ourselves. So hopefully we can get a little bit better at that. I'm also really interested in what at the end, you were talking a little bit about the new therapies that are being developed. And one, as you said, that's receiving a whole lot of interest is gene therapy. So, and I think people hear gene therapy and they have no idea what anyone is talking about. It seems like this to me, like I will just speak for myself, it seems like a little bit futuristic and everything, and which is not a bad thing. But can you help us understand that a little better and what is going on and what is happening with gene therapy?
Yeah, so we can affect things in several ways. We can potentially be able to alter genes when they're abnormal back to normal. We can silence genes so they don't make an abnormal molecule, or they don't make a molecule that interferes with the normal process. We could activate a process that's helpful to the heart but has been turned off by disease. All of those ways are affecting the genes that regulate things. And now there are a number of sickle cell anemia now we know we treat with gene therapy. There are early real successes. We can silence genes. For instance, there's a disease that many people here may have heard of called amyloidosis, where an abnormal protein is deposited in the heart. And we have all new of types therapies for that, where we can silence genes, where we can block the protein production. So there's a number of treatments there that are really promising, but we need to have the right way to get these things into the cells. And then we have to test them. And it makes me always, I don't want us to end at all today without making sure that the importance of clinical trials is not just in developing new therapies. I think it's important for everyone to understand that people in a clinical trial, even if they don't get the treatment, if they end up to be the control, everybody in clinical trials does better than if you're not in a clinical trial. That's been reproducibly shown year after year after year. There's more attention to detail. There's just more of everything. So even being in the control group is not necessarily bad. We have shown, and when I say improvements, it's not just improvements in quality of life. We've seen that patients' control groups in clinical trials can have improved mortality over what they would have if they weren't in the trial. So it's really important for us to do these trials and to find out, so that we can inform people properly, how much does this add to your life expectancy? How much does it improve your symptoms? And what are the side effects? And what's your decision, so that we can explain and give people the chance to participate with us in making those decisions for their health.
Yeah. And we, so WomenHeart has a site that we've created on clinical trials and the clinical trial journey. And there's a bunch of information, just like you said, in there that can help patients really understand the benefits of being in a clinical trial. Like you said, even if you're not in the, not on the medication or the therapy, but you're in the control group. And so I would encourage all of you guys to go to the WomenHeart website and look at that, as well as we have dropped in the chat box, just for all the people attending today, a wonderful educational piece on clinical trial for HFPEF. And that being said, and so you can just download it and grab it as this goes on. But that being said, what is it about HFPEF that makes it such a good target for this gene therapy?
Well, I think I don't know if it's any better than HFREF. It just what we have. We aren't quite as good at gene therapy and HFPEF yet as we are at HFREF, although we will be. But because we understand some of the enzymes and proteins that the genes code for a little bit better in HFREF. So for instance, in HFPEF, we now know that a lot of the problem there is that we get fibrous tissue, stiff fibrous tissue, like in a scar in the heart. Yes. And we need to be a little bit smarter there. How do we control that fibrous tissue? And when you get rid of it, what happens? The heart being stiff is not good, but if you take away all the stiffness, would it just be flabby? So there's a number that we need to study more. And that's why some of these are so important, is if we upregulate this gene or a product of the gene, how much better will we be? So we're understanding heart failure with preserved EF a lot better. What are the different gene problems that we can upregulate or downregulate or block?
Yeah. So that being said, are there certain patients or certain people, because of their genetic makeup or some other factor, that are better candidates for these types of trials?
Yeah, for gene therapy, it depends on what is being developed for what. You'll have to see the very specific indications. For example, there are some now, Ask Bio, who you said was supporting this, is doing a trial in heart failure with reduced ejection fraction to see if we can help with the contractility of the heart, how well it squeezes, because that's a major problem when you lose muscle cells. So it depends on the specifics. And the disease, amyloid heart disease, which deposits an abnormal protein, therapies there are different therapies that try to, not often genes, but some other molecules that just will silence the genes that make this abnormal protein, or make the genetic material that makes this protein and silence that. So it depends on the specific illness. But now, in virtually every one of the diseases that causes heart failure, people are thinking about different types of therapies that are gene therapies.
Yeah, that is really exciting, and we're just so thankful for all the companies and the researchers who are doing research on this to help patients come up with new solutions to stay healthy. And so I'm gonna move on and bring our lovely champions in. But one of the things is, if you go to womenheart.org, and I'll say this again at the end so you have it, we do actually have educational pieces on heart failure. We have it on cardiac amyloidosis and all these different things. We look in our Red Bags of Courage, or we have a virtual Red Bags of Courage, and there's so much good information in there. So we want you to make sure everyone goes to that. So now we get the lived experience. I'm so honored to be joined and by not only Dr. Lindenfeld, but two wonderful WomenHeart champions who are going to help us today understand how their experiences of living with heart failure. So we have Kimberly Cannell, who is a wonderful WomenHeart champion based in Texas, and she was diagnosed with heart failure and eventually received a heart transplant. And we also have our wonderful Sheila McCarr, who is a WomenHeart champion based in Minnesota, who is currently living with heart failure and I believe has an ICD device. So you're an ICD sister with me as well, Sheila. So I want to start just by, if both of you, and you guys are wonderful at doing this, if you could share a little bit about your diagnosis story, like symptoms you may have had and how you were ultimately diagnosed. And Kimberly, if it's okay, I'll start with you and then go to Sheila.
Okay, hello everyone. I am Kimberly, as Jody stated. And for me, when it came, well, my symptoms, if I could talk about that first, I was fatigued all the time. I was one of the children that couldn't play, couldn't ride bikes, couldn't jump rope, couldn't run, couldn't do any kind of activities because I would get extremely tired fast. When you did the presentation, I'm like, wow, it kind of took me back to my life at that time because that was me, like, especially laying flat and having to rush back up to breathe because I would get so short of breath. And those symptoms were really for years. So for me, I was 12 years old. I just had a common cold and cough. I went to school and they wouldn't let me stay because I was sick. So they called my mom to come pick me up, and she was taking a test at the time because she was in the medical field as well. And she took me to the emergency room. And when the doctors came in, they listened to my heart. One doctor made a face. He went out and brought several more doctors in, and they all kind of looked at each other like, okay. And so I'm 11, 12, so I don't have a clue what's going on. So they began to tell my mom that I had a heart murmur at that time. And so I just remember at that moment, my life completely changed. It was doctor's visits weekly, monthly. My childhood, that's what I remember the most. I don't remember having like fun or you going places or, I don't have that memory. My memory is doctor visits at home in the bed. My mom's scared for me to do anything because I had episodes of passing out before and just always I when I first got on the medication, I had to spend maybe like a week out of school just so that my body could adjust to it. Because when I first started, I would just fall asleep. I wasn't accustomed to it yet. And so that was pretty much how I was diagnosed. I just had a cold and a cough, and it went from a heart murmur to hypertrophic cardiomyopathy. into heart failure. And then, of course, I'm transplanting them. So that's kind of the elevator version of my diagnosis.
Yeah. And so, and the cardiomyopathies, as Dr. Lindenfeld was describing, one of the three most common causes is heart muscle disease.
Yes.
That can happen at any age. So, a lot of people think, well, this is what happens when you get older, but actually that can happen at all different ages. And, hypertrophic cardiomyopathy is very common. It's common in young people who are doing sports, or young people like Kimberly. So that's, it's unfortunate that you had to go through that as a child. But thank you for sharing with us. Sheila, what about you? Tell us a little bit about your journey.
Yeah, so my name is Sheila, and I'm a 57-year-old woman. I'm a WomenHeart Champion of 2020. I had fatigue, and I also I had a sharp pain and shortness of breath. And my mother is a heart patient, had me go to the hospital, and my troponins were elevated. And so I met with a cardiologist, and I was diagnosed with myocarditis. And so they treated me for the myocarditis, and then for 10 years, I was treated for cardiomyopathy, which is the weakness of the heart. And I was diagnosed in 2006, and then 2016, I was diagnosed with dilated cardiomyopathy, which is heart failure, and it's the electrical part of the heart. And I'm highly medicated. I'm like on 10 medications. And then in 2019 or 2018, my brother, who's a doctor, decided to do gene therapy or test all his genes for the heart because my maternal grandfather died of a heart attack at 50. My mother was an LVAD patient for 10 years, and then I was diagnosed with dilated cardiomyopathy. So in testing the genes, one came back positive, the FLNC gene. And so I'm one of 5 children, and so we all were tested. My mother tested positive, and then 3 of the 5 of us tested positive for the FLNC gene. And so in 2019, we all had an ICD implanted, which is a defibrillator and a pacemaker. And 2020, COVID, I have my routine. I'd get up and go run and come back, have breakfast, and take a shower. And while I was in the shower, my heart rate went to 300 beats per minute, and I had a cardiac arrest, and I fell out of the shower. I had a 2-inch cut in my face, and my defibrillator saved me. So thank you to my brother. I'm here today, and to the ICD. And so today, 2025, I'm doing great. I have great care. My ICD gives me a lot of confidence. So people going through this, there's a lot of hope. And I have to say that from my symptoms to where I'm at today, I feel so fortunate to live in the United States and with the doctors we have, because what they knew in 2006 when I was diagnosed to what they know now it's incredible. And I hope for my children it's going to be a different journey, because my journey is very much different than my mom's. So thank you.
Thank you so much for sharing that as well, and how scary like to have that happen. And we're so thankful that you did have that ICD defibrillator. And the fact that both of you took a really tough experience and you decided, I'm going to give back and I'm going to help other women like me, right? And you use your story to help others. So I guess the next thing I want to know is, like, what would you tell people if they're like on this journey of getting a diagnosis, or they're at high risk? Let's say they have cardiomyopathy that can lead to heart failure, they've had a heart attack, or they have heart valve disease, which Dr. Lindenfeld shared are the most common, although also diabetes, obesity, and there was one other thing I can't remember, but high blood pressure. So what would you say to any of those women to help them feel empowered and more supportive? And Sheila, I'll start with you since you did the first time.
Okay. First of all, you're not alone. And secondly, be an advocate for yourself. And, until you feel like you have the answer, that you you know your body best. And I think that you have to be an advocate for yourself. But like I said, we're fortunate to have the doctors and where we're at with science today. It's pretty impressive. But anyway, you're not alone in there, and also get support. In 2020, when I came, or 2019, when I came home from the hospital after my episode, I was, I felt alone, and I got on the internet and I found WomenHeart, and I became a WomenHeart champion. And that has been great because my story, it's nothing compared to other people's stories. It's very humbling, and I think support and be an advocate for yourself is two things I would give advice to.
Well, thank you. And so what about you, Kimberly? Thank you so much, Sheila.
Well, for me, from experience, I would tell women to give themselves permission to have good days, happy days, because it's such a roller coaster, living in the life of heart disease. And like I always say, there is life after heart disease. That's kind of like my motto, because I didn't know that it would be until my life became what it is today. So that's one of the things that I will always say. There is life after heart disease. You just have to figure out what that is for you in your life. And of course, for me, being a part of support groups helped me tremendously, and which led me to Women Heart. So that would be another thing that I would add. Get a support system, because it's necessary and it's healing in itself. It really is.
So, yeah, it is, having that someone who really understands you. It's not, your medical professionals are wonderful, and we're so glad for people like you, Dr. Lindenfeld. We're so thankful. But talking to someone who kind of gets you, you've been through some of the same things, had an ICD, had a transplant, it really can help mentally, and it can help you physically too, stay healthier. And so speaking of that, like both of you have had to manage a lot of medications, procedures, doctor's appointments, and many different things during your journey, like many, many years of it. And Kimberly, since you were a child, 12, 13. So I'll start with you, Kimberly. What advice can you give people about how to manage and their treatment, their medications, their appointments, and all of that? Do you have some advice on that?
Um, First, I would say managing everything is a challenge. I've met people that did great. I've met some people that fell off. I remember being in a hospital with a lady. We were close in age, and she had just stopped taking all her medicine because she felt overwhelmed.
Oh,
And in my mind, I couldn't fathom that, because it was every day what I had to take. I never missed a dose. I had an alarm clock set for everything, just anxious about it, because I didn't want to end up back in the hospital, which always happened. But nevertheless, I still made sure I took all my medication. And for me, I stayed in the hospital a lot. I can remember times where they would drain 15, 20 pounds of fluid off of me,
oh my God.
so that was just my life. So for me, I would just tell anyone, maybe like have like a accountability partner, someone that kind of do it with you. And I know that's hard, because I've learned in my years that everyone can't be on that journey with you, because they become overwhelmed as well. And it's not like you're intentionally trying to put your load on them. It's just that because they don't understand, which is why we have the Women Heart, where you find people that do it, that makes it challenging as well. But I would just say take it one day at a time. And what I did was I set alarm clocks. If I had medicine at 9, I just set that alarm clock. And when that alarm went off, I knew it was time to take medicine. And that's the way that I manage. And I feel like always listening to your doctor is what, of course, communication. You telling them how you feel, they telling you back, and because together, it's powerful. Because doctors, they know so much, but then you are in your body. So you can also tell them things that, okay, well, let's put that together and let's figure this out. And I've done it so many times. So I would say just one day at a time, manage it with alarm clocks if that works for you, and just always be in communication with your nurse or your doctor, because that helps as well.
You know, a lot of people forget about the communication piece, and that is such a good piece of advice, Kimberly, because, you know, sometimes we just like, oh, I don't want to bother them or anything like that. And I think that's especially true for women. Again, I may be stereotyping, but we're like, we don't want to bother anyone. We don't. I've done that. But it's a really important, like you said, to communicate. And if you're having something different go on, or something's not working, or you're having side effects from medication, is definitely have that communication. So what about you, Sheila? What would you suggest to people to help with management of medications and all these things that go on?
Definitely communication, but also listen to your doctor. When I was first diagnosed with myocarditis, you know, I ran marathons and had never taken a medicine in my life, and they prescribed me two medications, and I thought a virus, in my mind, took its course and it got better because that's what I was always told and brought up. So I did not take my medication at first, and then I got pregnant. Thank God I wasn't taking my medication, but had I listened and asked more questions, communicated, um, you know, it'd have been, I probably wouldn't have had my third child, but I probably wouldn't have been, I would not have been this far along in my, I probably would never have gotten heart failure. Who knows? Um, but also like prioritizing your medication. I mean, medicine is so important with heart failure. I mean, it's the first thing I do in the morning, it's the last thing I do at night. And I think, you know, prioritize your health. Like doctor said earlier, you know, women a lot of times are the last to take care of themselves. But I think when you are in, you have heart disease or heart failure, you should really, it's so important, medication and rest and taking care of yourself. So.
Yeah. 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 And that, you know, that can be hard to do. A lot of us, we're busy, like busy is a status symbol these days, you know, and, but that taking just a little bit out of time, at time here and there, like get some rest or do something, walk outside or do something for yourself. And I want to leave time for questions. I know we're getting close to that time, but, and I want to remind you that there's the educational piece in the chat box you can download. So I want you to do that before we close the webinar, because then you won't have it. But I want to, and would like to start with you, Dr. Lindenfeld. I'm going to ask you all the same question. And that question is, and you just heard from these lovely women as well, what gives you the most hope for the future in terms of dealing with heart failure?
I think we look at what both Kimberly and Sheila have told us about their lives and what's happened and how much things have improved each decade. And the thing that gives me the most hope is that as long as we maintain our scientific base of investigation and we, you know, really keep the basic science that then becomes treatments that we test, as long as we keep to do that, things are going to get better and better and better. And it's really important, I think, to understand that what we do, I haven't done anything the same way every time 5 years changes in my career, and I've been delighted by that. It's just so much fun to be able to say, I can do this now. We can do this together now. You know, you can get better. So I think there's just huge promise out there.
Yes, for sure. What about you, Kimberly?
Say the question to me again, Jody. I'm sorry.
So, no, what gives you the most hope? So it's just simple. What gives you the most hope?
Well, I want to make it simple. So basically, I do the Texas Heart Institute, and I've now seen where they have even advanced transplant. Like, so they are doing it to like I can't remember exactly, but basically it's more advanced now when it comes to being transplanted. So for me, what gives me hope is to know that in the future, that from when I receive my transplant to later on, it will be even more advanced and, you know, better for me if that ever happened again, because like now I know about 3 of my heart sisters that are already needing heart transplants again. And two of them are transplanted already. So I can't say that would be my life. I don't know. It's unpredictable. But in case it was, I'm seeing that everything is getting better, you know, as time passes. And for me, that gives me a lot of hope because I do have a daughter that I want to be here for. So I'm hopeful no matter what it looks like. I'm just hopeful because I feel like if I've come this far, then I can go some more. And that's just the way I live my life.
Absolutely. And she is very beautiful, by the way. What about you, Sheila? What gives you the most hope?
M- Um, Personally, the collaboration that doctors are working with patients and listening to patients, and I think it gives me hope that you're being heard, and that helps them with the science. And I want to live to be 100. My mom lived to be 82. I want to live to be 100. So with my own heart, maybe not, but I would love to just with science and what we're learning, keep the collaboration going. I think there's a lot of hope for the
Yeah.
future of people living with heart disease.
Yes, and you all are helping that happen by being here today. So again, we just want to, we appreciate it so much. And we have some questions and we're going to try to get in as many as I can. But remember, there's all sorts of educational pieces on womenheart.org. So go there. We have our virtual red bags of courage. They're really cool. So don't forget to go on there if we don't get to it. But I'm going to try to, let's go as fast as we can. As we want the first question, Dr. Lindenfeld, is can HFPEF turn into HFREF?
Yes, it can, but that's not usual.
Okay. And good. Thank you. That was so good and short. But I was curious about that too when I saw it. The second question is that obesity obviously can lead to HFpEF, but can having heart failure lead to obesity? Does it affect your metabolics?
So heart failure, it affects your metabolics, but the primary way it can lead to obesity is that you're unable to exercise as much. But I think it's important to understand that exercise is it's very important for your overall health, but it's really hard to lose a lot of weight with exercise. So it's really still eating that makes obesity. So heart failure can, but it's not a huge cause of obesity.
Okay. Another quick question is, have you seen a increase in heart failure since COVID?
Well, we saw a little bit of a spike during COVID. Actually, interestingly enough, we found out here at Vanderbilt that at the beginning of COVID, our hospitalizations for heart failure went down 65%. And we don't know why exactly. No one knows why. Even in clinical trials, all the hospitalizations for heart failure went down during the beginning of COVID. We think that's because people were home more often, stuck to their diets, took their medicines. And as one of my patients told me, yeah, I don't go out to McDonald's for lunch every day anymore. So that can cause the myocarditis, but and of course, when you're ill and if you have a heart problem, any kind of underlying illness will make the heart problem worse. But I think it wasn't a huge part of the COVID epidemic.
Yeah. Well, one thing that we noticed is some people weren't going into the doctor because they were afraid to. So maybe that as well in addition, but that's really interesting. Are there ways to increase ejection fraction?
The medications for heart failure with reduced EF, the medications on average improve ejection fraction in the range of 10 to 15. So you start at 30, the average person will go up to 40 to 45. And the beta blockers are the ones that do that the most, but I don't want to say that's the best medicine because all of those medications together have a substantial effect on how long you live and what your symptoms are. But yes, the ejection fraction with reduced EF will generally go up substantially with those medications.
Okay.
And they have to be started and then increased to the proper dose too.
Okay. Well, that is hopeful because, treating, we talk about getting the treatment, and Kimberly talked about making sure you take your medication, and so did Sheila. So that is a good thing to remind everyone. And very last question, and then we've got to end, and I'm sorry, you guys, but LP little a lot of people are talking about that now and how that can increase your risk of, my guess is because it can lead to heart attack. Is that right? Does that increase your risk of heart failure?
Well, anything that increases your risk of coronary artery disease and heart attacks increases your risk of heart failure. So now we can treat what's called the low density or LDL cholesterol, the bad cholesterol, quite well. For a while, we ignored the LP(a) because the statin drugs were so effective. But LPA beyond that, it's really determined genetically. And that can be something, if you have unexplained coronary artery disease where your risk factors don't explain it, then you should be screened for an LP(a) because that can be another cause. And there are now drugs that can specifically treat that and more in the pipeline.
Well, thank you so much. I know we're out of time. I could sit here and talk to you guys all day. This has been excellent, and we really appreciate you. I mean, you've covered the gamut with this, all the way to new and innovative therapies that are really exciting for a lot of us to hear about. So we just appreciate you being here today. Again, WomenHeart.org has a lot of resources, and don't hesitate to connect with us. And thank you, Kimberly, Sheila, and Dr. Lindenfeld. You've been wonderful, and we really appreciate you being here today. And all of you who attended, thank you so much. We've gotten a lot of good feedback already. Bye, everyone.